With BCC, there are two types. There's nodular and there's superficial. The most common form is that nodular one. Okay? These things pop up, right? They grow slow, generally asymptomatic. It doesn't hurt them or anything. It's just looking odd and weird. So the most common form, again, is that nodular one. You get that pink skin colored. It's that pearly, firm, dome-shaped papule. It's got that rodent ulcer associated with the nodular one. So ulcerates and has elevated rolled border and telangiectasis. Okay? Superficial, that's out there too. You get that circumscribed round oval plaque. Clinical presentation, usually, this is those lighter skins, right? Over 40 years of age. Most common presenting complaint, bleeding or scabbing or sore, heals, goes away, but it comes back and forth. So it's that zit that won't go away. Some of those locations specifically related to the two types, right? So nodular, that's the most common BCC. 85% of those are on the head of the neck. Most common site is the nose. Superficial BCC, the most common site is of the trunk. Malignant potential. BCC advances by direct extension and destroys normal tissue. Long-standing lesions replace vital structures throughout that spreading. Untreated, it can destroy whole side of the face and even subcutaneous tissue, bone, and invade the brain. So it can metastasize, so it can get bad. It can, fade into those areas, but we're not specifically defining it as that metastasis. So almost never metastasize, but it can, if it's untreated, it can have some of that spread. So we can see there some of these pictures here. It's on that nose, the nodular BCC, most common nose. We have that papule, shiny, pearly, telangiectasis. Those things are out there, okay? If you think that it is BCC, refer, okay? So we're going to get them out. And why? Because a treatment for a BCC, regardless of where its location is at, it goes into what is called Mohs surgery. And we're going to look at a slide here showing that. That Mohs myographic surgery, that's that multi-step removal process. So they don't cut it all out at one time. They'll see them and then they'll follow up and do more and more and more. And it's just trying to build a new skin for them to have. Prognosis is very good. High recurrence rate. Okay? A key component here, once they have the BCC, it's cut out. We are going to still be doing of those total body surface examinations annually. Something specific about BCC is if they go 3 years and it doesn't come back, they can stop TBSA. It can stop. That's what you can do with BCC. So may discontinue after 3-year tumor-free. There is Mohs, breaks it down, showing how they're getting up and under. Again, once we're doing these excisions, whether if it's BCC, SCC, melanoma, those things, we have to do those wide excise. We got to take even some of the normal skin just to make sure we don't leave a single cell behind. So there we can see that on that upper nose bridge area. That's a more focused one of it. So we see that elevated papule. A little bit looks like it's dome shaped, but the telange that is in there, specifically BCC. More photos. It's that shiny. You get that border, that's the outside, that it's almost like that rise, so it comes up and over like that bridge that is there. Not only can this be on the skin, sometimes you can have it get into that gingiva over there, right? So this thing probably started on that upper lip, right? But then it just spread around. Didn't metastasize, that's just spreading out so it gets into that there. I don't know how long that's been there, but yeah, even worse. Okay, that is, okay. Mohs, I talked to y'all how it's not just a one excision, quick and fast thing in and out. This is where they have these individuals that are having it to be taken out and then put back together, suture it up so that it can then have that normal looking beautiful skin, right? So up top, that's that BCC. We see some of that white excision that is happening. So we're pulling it down and out, and then we're re-tagging it up so that we can make sure that that BCC is out. Another picture of Mohs. We see how they're getting wide and out. You can even borrow some skin from other areas to put those, to basically transplant them, okay? Again, I've never been in one of these things, but dermatology, Mohs surgery, BCC. And there you can see after the fact. So they put those other skin over there, covered it up. Does it look perfect? No. Does it look better than the BCC that was there? Yes. Okay, so it helps that. So that's Mohs surgery. Up next, let's get into that AK, actinic keratosis. We talked about some of those things yesterday that could preclude or turn into some of that SCC. Well, AK is just like that. So AK can equal and get into that. Pre-malignant. Etiology-wise, you got that chronic UVB. Again, fair-skinned, more prone. Superficial atypical squamous cells, limited to epidermis. Persistent, so we got that localized, rough feeling to the skin. Erythema with scale, so that's that hyperkeratotic lesion on the ears and the dorsum of that hand. You have that sharp adherent yellow scale as lesions progress. May present as cutaneous horn. We talked about that yesterday, right? Cutaneous horn, we want to rule out SCC. But it also can be seborrheic keratosis, which we talked about yesterday. That one must rule out SCC. So this is similar to those things. We don't want them to progress. Again, sun-exposed areas, so the head, the neck, trunk, extremities, lower lip, actinic cheilitis. Increased number with age, right? So it gets into those light-skinned elderly people who have had that sun exposure for their life. Increased sun exposure now being seen in younger patients due to excessive sun exposure. So they're out there going to the beach, party it up. If the lesion is on the superior aspect of the pinna and tender, think chondrodermatitis nodularis helicus, a degeneration of underlying collagen, excisit, special pillow for sleeping. This is just a component of AK. So if it's located on these exact locations, then it gets a formal diagnosis of the CDNH. So that's out there. It's AK, but it's just on that specific area. Discuss photoprotection, barrier, chemical, cover it up. They'll be getting some of that TBSE. If they are having some of that AK, treatment-wise, if they've got a few, they have individual lesions, then let's cryo. If they're having multiple lesions, so it's not just one, then we can refer them off to Derm. Standard-wise, they'll be using some of that 5FU. Alternative is that Aldara. Thicker crust, indurated lesions, then they will do some of that excision once they know for a fact that they've got the AK. Prognosis, 10 to 20% will develop into SCC over the 10 to 20 years. Again, this is that rule out, or this is that differential diagnosis if we think that this could become that SCC. Photoprotection will decrease number of new lesions and resolve small lesions spontaneously. Again, pre-malignant, SCC, okay, AK can, it's almost equal to SCC, so that's why we want to figure those things out, biopsy them. It's got that yellow crust, right? If it's one and only, then let's fry them. Let's cryo them. If it's all over, Derm, off you go, because they're going to give you 5FU or Aldara. So that's on of that trunk up there. More of them. You've got that crust, that yellow. That's that CDNH. So where that's at. Derm, like we said, that will start off with that standard treatment. The standard treatment of AK is F5U. And it looks beautiful. Okay. What does in situ mean? That's Latin for that in position, on site. So Bowen's disease is squamous cell carcinoma in situ. So this is talking specifically about Bowen. It's that keratocytic dysplasia involving full thickness of the epidermis without inflammation of atypical cells into the dermis. Bowen's, again, well-defined borders, slightly elevated, red, scaly plaques, very slow lateral growth. Most common locations for the women are in those lower extremities, those beautiful legs. For men, the scalp and the ears. That's where the most common locations for Bowen's disease is located. Clinical presentation, we got that lighter in life, sun-exposed skin, not localized to a visible lesion laterally. This is the epidermis only. Treatment, small, ED and C, so that electrodesiccation and curettage, so ED, so we're frying it and then we're scraping it off. Larger lesions, Derm. It's the same thing as AK. So that's standard. The first thing they'll use is that 5FU. They can get in Aldara, or they can just want to cut it all out. It's got low-grade malignancy of that potential. Slow growth, but it will progress into invasive SCC if we leave it alone. If we don't do anything, then it can get into that SCC. Every 6-month follow-ups required. Recurrence is common. So if it is Bowen's, you can treat that one and it can go away, but it could pop up somewhere else because that is common. There we go. Bowens, I like this picture because I always make a joke because it's in there and the treatment is what? 5FU, right? So that's all. I like it, it's fun. Okay. There we go. Again. So that's Bowen's disease. An aspect of Bowen's disease, specifically known as erythroplasma of Horat. So SCC in situ, like it's Bowen's, but this is of the mucous membrane. So this can be happening inside of your mouth. So uncircumcised elderly males, vulva of elderly females, and or oral mucosa presents with moist, red, smooth, slightly raised plaque associated with HPV-8. Erythroplasia of Querette, HPV-8. Same treatments, but that's what they look like. So this component of Bowen's disease in the mucosal membrane, so it can be in the mouth, it can be on the vulva, it can be of that uncircumcised male, so on the glands of the penis. So that's that. Now let's get into the balls. The balls. SCC. Second most common skin cancer. What was the first one? Yeah, BCC. So this is the second one. But this one has that high risk of metastasis, etiology, cumulative sun exposure, UVA, UVB, AKs are the most common precursors. So we've talked about those things yesterday that could get into SCC. Well, AK is the number one that can advance and get into SCC as that precursor. We talked about it could also be Bowen's, it can be, thermal radiation burns, chronic irritation, HPV, inflammation, immunosuppression, arsenic exposure. So these are those things that can cause and can push into that. Red, scaly, persistent, usually with deeper involvement. It can have ulceration or it cannot have ulceration. It's not one of those things that it's going to happen every single time. We've got hypertrophic lesion with ulcer and hyperkeratosis. We talked about the cutaneous horn yesterday, right? Cutaneous horn can develop into SCC. That's one of those things out there. It can happen on our lips, and we'll have, and seen in all of those photos, is that ulceration with that induration that is out there. Like always, sun exposed, scalp, backs of the hands, superior surface of the pinna, anywhere. Management-wise, small lesions arising from AKs, so we're going to do that same thing as AK. We're going to do that ED and C. Larger lips, larger lesions, and those on the lip, we just need to excise those things. Right? We need to refer them over to Derm because Derm is going to cut it out. Also make sure that we're going to be looking for that examine lymph nodes. Okay? What is different of the TBSA for SCC as opposed to BCC? BCC, if you don't have that stuff for 3 years, good, you don't have to do it. SCC, you're going to do annually for the rest of your damn life. Okay, we're going to be looking over and over and over. So follow up every 12 months for life. Of course, sun protection. Go ahead. Prognosis, aggressiveness varies with cell differentiation and lesion location. Longer history of unprotected sun exposure, so we need to go ahead and teach them, cover that up. Overall, significant potential for metastasis, so they can jump out, especially 11% of the time if it's on your lips, it is going to jump around. Jump around. There you go. Scalp. back of the hands. There's the lips. Excise that also. You can see all of the ages here, right? These are older people. This is elderly that have had this sun exposure since they were young, and it develops and gets into those things. Can you hear me? Can you hear me? I don't know. I'm not. Okay. So, BCC, AK, Bowens. Bowens had those other ones that is associated with that ear, and then we talked about the SCC, okay? Key components were out there that are specific to these disorders, diseases. Any questions before we take a quick break, and then we'll start it right back up? All right, let's take a break. So let's start back up at 1:25. Class advisor, and she knows that I'll be done by 2, so she will be in here.
Woo!
So we're going to talk about nevi. We're going to talk about the special types of these nevi that can occur. Becker's, nevus, halo, blue, Mongolian. Like, we're going to get into these things right there. So again, there'll be some key components to each and every one that is specific to in and of itself. So, gotcha. Nevus. Benign growths composed of nevus cells derived from melanocytes. So basically moles. This is what we could have, moles. Nevus cells differs from melanocytes, so larger, lacks dendrites, has more abundant cytoplasm, and contains coarse granules. One of the things that is going to be a big key component that is in bold and red and large, important, are those ABCDs, okay? DEs, ABCDEs, asymmetry, border irregularity, color variation, diameter, if it's greater than 5 millimeters, mo bueno. Evolution, so it's changes in the size, the shape, the color, it goes back and forth, right? So, memorize these ABCDEs because y'all are going to be using this throughout all of these block 3 stuff, especially once we get into the cancers tomorrow. So, melanocytic nevus, so common, become large during pregnancy or puberty, peak, gets up to its biggest thing, 4th to 5th decade. Yeah, like, my goodness. If we took a shot every time we talked about sun exposure, we'd be fucked. But anywhere, to include the palms, the soles, and mucosa, okay? So that's where this stuff is at. Melanocytic nevus, sharply circumscribed, uniform colored papules and macules, irregular surface with or without hair. So it could have a hair. Single or multiple, size varies greatly. Appearance and history, of course, we're going to be wanting to do some type of a biopsy so we can see those nevus cells. Biopsy any lesion if change in appearance, right? So that's part of that ABCDE, right? So we have that change that could be happening. If we're seeing these things that are changing, then let's go ahead and biopsy them. There are 3 types of melanocytic nevus. Oh, well, first, treatment, none necessary, basic maybe cosmetic removal, okay? Excise it if we think that. But let's break it down into the 3 different types of melanocytic nevus. So we've got junctional, we have compound, and we have dermal. So these are those 3 subtypes of common acquired melanocytic nevi based on location and the nevus cells in the skin. So when we biopsy them, then we can see that. More important though, it's got its physical appearance that is different. Can occur anytime after birth, affected by hormones and sun exposure. So that's a chart that breaks them down. Junctional, It's flat, but it can be slightly elevated. Compound is slightly elevated, dome. And then dermal, dome, warty, polypoid, pedunculated. Those are those things that are specific out there in regards to what they are, which type of a melanocytic nieve is it. So let's start off with junctional. Flat or slightly elevated. What we see in this, light brown to brown black with uniform pigmentation. So we see where those borders are at, okay? Size, small or can get up to 0.6 centimeters. Nest in the epidermis or epidermis dermal junction, most common in childhood. Childhood after age 2, and it may develop into a compound. So it can go and get more elevation to it, so it's going to turn it into of a compound. So they can advance. Clear borders. You can see these nevi, they can have hair or they cannot have hair. It doesn't say it specifically due to it. Again, junctional. Compound. So slightly elevated, as seen on the picture on the right, or dome-shaped, as seen in the one in smack in the middle. Uniformly round, oval, and symmetric. White periphery, it's known as a halo nevus, and we're going to talk specifically about a halo nevus later on in this lecture. But that halo nevus is a compound nevus. Nest at the dermo-epidermal junction and upper dermis. Same chart. These things are showing specific to them. Again, with or without hair. Dome shape. Dermal nevus, dome shaped most commonly, but it can also be verrucous, pedunculated, or sessile. Skin color to brown, black, with hair. This one with hair. Common in adults. All nevus cells in dermis, sometimes in fat cells. So it's just basically having how far down they go, okay? If it's a junctional one, stays up on the top, but then it can go a little bit lower into the dermis as it becomes compound, and if it's getting into sub-Q area, so it's going even lower, then that can be dermal nevus. Same thing. Photos. It's that dome, pedunculated. There's Rudolph. All right. So now I'm going to take those three types, right? So we've got junctional, we've got compound, and we've got dermal. Now, all of those things can be fit into one of these special ones, so that's what we're going to go through, okay? So let's start off as we're coming out of mama. So you get a congenital melanocytic nieve found at birth. You get that birthmark. 1 to 6% of all newborns are born with these things. Are they going to go away? Yes, but they start off. Vary in size from less than 1 centimeter or get it up to 20 centimeters. So it's their entire back or ass or something, who knows. Classification based on the size, so small, medium, large, giant. Greater risk, greater or equal to 5% BCA or 20 centimeters, greater than 20 centimeters. Most grow proportionally with the child. So So there we go, management-wise, if it's a small or a medium, we're observing for malignant transformation, right? So we will teach the mom, dad, or anybody about the ABCDEs. If they're seeing those changes of the ACBDE, then we need to get some biopsy, some look stuff at. If it stays the same, then okay, it's good. This is just a congenital nevi. If it's large or giant, then prophylactic removal is indicated because of the fact that they will have that 2 to 7% malignant melanoma risk. 50 develop by age of 5. What do they look like? Okay, so dun, dun, dun. The whole back, the trunk and the ass. So these are things that have been there a while. And they're there. So that's that special one. Now let's talk about nevus spillis. So speckled lentiginous nevus. Any age, most common in adolescence. It doesn't matter if it's a male or a female because it can be occurred in both sexes. Morphology. With nevus spillis, it's hairless, oval, irregular shaped brown macule, dotted with darker brown to black papule spots. So it looks like it's got those freckles on it. Hairless. It can happen anywhere. It's not related to the sun. None is needed. It's rare that it would develop into a malignant aspect. But there's the picture. Nevus spillis. You got those freckles in there, so you get that darker brown to black speckled. So that's what they look like there. Becker's nevus. It's called a nevus, but it's not a true nevus because it lacks nevus cells. Clinical presentation, oftentimes seen in those adolescent men, either a brown macule or a patch of hair or both. Basically, Becker's, think hair. It looks like, yeah. Locations, most commonly, unilateral upper back, shoulder, upper arm, or submammary, so on of the chest. A key component to this Becker's nevus is that it's unilateral. It is not symmetrical. It's not bilateral. This will happen on one shoulder, one side of the chest, one side of the back. So that's what it is there. Never reported malignant potential. Treatment-wise, usually too large to remove with excision, right? So we'll see pictures. This is like a patch of hair growth, like you got a damn, something. Anyways, hair may be shaved or permanently removed. They can do some of that cosmetic stuff out there if they want it to go away. Again, unilateral, right? So that's, damn, hey, you got some hair. Okay? That's Becker's nevus. Becker's. It's oftentimes seen in men, but it can be in female as well. So that's Becker's nevus. So now, let's sing Beyonce about that halo. So here's halo. Clinical features. So you get that compound or dermal nevus that develops that white border. So you've got that dome-shaped nevus, but it's got that hypopigmentation around it. So it's got that halo on. Typically occurs around the age of 15, may herald onset of vitiligo. If it's the very first one, then you might be getting some other ones because it could be, let us know, hey, vitiligo might be on its way. Malignant conversion is rare. One or more hypopigmented to white lesions that contain essential red, brown to black nevus. No melanocytes in the halo. So it's all hypopigmentation. After a decade or more, they could have some of that pigment returns, but doesn't always happen. Okay? Most commonly, we see this on the trunk. Never on the palms or the soles, because we will talk about some stuff that are specifically on the palms or the soles. Treatment, none needed. If we think that it can have some malignant transformation, if we've done A, B, C, D, E, and that changes are occurring, then of course we will want to do that biopsy to check it out. Just like vitiligo, which we talked about in the past, we could do a Woods lamp that would show us if there are some that we're not seeing yet, but that hypopigmentation is already starting to happen. If we were to put the Woods lamp over it, it'll flare, or it'll show us where it's at. Again, there's that halo. More halos. Okay. Spitz nevus, aka known as a benign juvenile melanoma, termed due to histologic similarity to melanoma. Occurs most commonly in children, but it can be in adults. One of us could be having one of those. Most commonly on the head, neck, lower extremities. Hairless. Red to reddish brown, dome-shaped papule nodule. There's the size, right? 0.3 to 1.5 centimeters, often appears suddenly. Benign juvenile melanoma. There is one treatment for Spitz nevus, and that is to remove it. So if you think that it's Spitz nevus, benign juvenile melanoma, then the only treatment is to path it, cut it off. Blue nevus, slightly elevated, round, regular nevus. Typically it's less than 5 millimeters, so it's not big. Large amount of pigment in dermis. All races can have a blue nevus. Most common on the extremities and the dorsum of the hands. Like we're always thinking about differential diagnosis. Blue nevus, often confused with malignant melanoma because of the color. It's that blue, it's that darker color that makes us think that it could be something. Develops in childhood, remains unchanged, so we want to, think about what it has been and how it dies. Like some of the other ones, there's no necessary treatment associated with this. It would only be some type of a cosmetic aspect that that patient would like. Request. There it is. It's darker. So we wonder, holy, it's not good skin color. There we go. Okay. Up next, we're getting to one of those newborn nevus stuff that we see. So Mongolian spot. It's that blue to black lesion, dermal melanocytes. Most often it is on that pre-sacral area, so just above their butt crack of the baby. Most common also, it can be seen on scalp. You can also see it on the backs of the hands, the face trunk, dermatomal pattern, birth to childhood, Tyndall effect. Yeah, so that's what's happening. We call it a Mongolian spot because it occurs most commonly in Asians and Africans, right? Asia, Mongolia. Blotchy, macular blue, black, or gray pigment, buttocks or back. We don't need to do any treatment of this. It will potentially fade away as they get older for that Mongolian spot. Inexperienced clinician may confuse with bruising. So, if we think that this is some type of abuse, then documentation could be in there. I've got that, in a lower font because that's not derm specific stuff, okay? If it's child abuse. There it is, that pre-sacral area, so just above the crack. Mongolian spot. Almost there. Last ones. Nieves of Oda. Nieves of Oda. Blue, black pigmentation of the first and second branch of the trigeminal nerve, right? So we're up here with the 3, so 1 and 2. Affects the sclera, conjunctiva, skin around of that eyes. It doesn't affect their vision, but it's still around that area. Occur at birth or later, darkening with age. Common in Asians, especially females. Treatment-wise, laser to lighten the lesions. But one of the key components is because of the fact that it is around that trigeminal nerve, we need to make sure that the vision is not changing, that they're not having side effects of their vision, because then that could be leading into some type of glaucoma. Okay, so Nieves of Oda glaucoma. And there it is. Talk about those Asians. You can have some of that sclera, so it's up and onto that eye. Again, if we're seeing those things, absolutely. We're going to have them do visual acuity test with us. More of that. Picture-wise, there we go. Labial melanotic macule. Brown to black macules on the lower lip. Labial, lip. Common in young adult women, resemble freckles, but no change with sun exposure. This is benign, but if it is cosmetically asked for, then you can do some of that cryo or the laser to help decrease that pigmentation. Last one, Nieves flammeus. It's that port wine stain. That was probably like her 3rd bottle of wine, and she spilled it all on her face. Not a nevus, but a congenital vascular malformation, commonly involved the face and the neck. Vascular malformation. What's that other vascular malformation thing talked about yesterday? Y'all remember? Pick the cherry, okay? Pick the cherry. Cherry angioma.
Yeah.
Yeah.
Women's health. Sorry.
Okay. Women's health is what's in your mind right now. I know that. Dr. Love. Y'all will love it. So, tomorrow, me and Dr. Klein are switching because she